Okay, Lucy, the stage is yours.
Thank you. Hope you had a good break. I've been asked to clarify one thing. I've used the term survivors to describe some of the authors of the framework. And in the UK, survivors means people who have survived the psychiatric system. It doesn't mean surviving an illness, because people who call themselves survivors don't see themselves as having had an illness. It means surviving the psychiatric system, just to make it clear, because I think it's a bit different in Norwegian. Great, so if I have lots of clever technical people who are going to now show a very short video. It's about 5 minutes. So this video is from the launch of the framework, which happened in London in January 2018. It'll introduce you very briefly to all the authors of the framework and a few other people who attended, and just give a flavour of what we were hoping to do and how that and what happened at the launch. So I will step aside. It's in English, but I hope it's clear enough for you to follow. If you can show the video now, that would be helpful.
I'm just really pleased with the way it's gone. People have understood what we're saying and engaged with it, and I think that's what we wanted. You know, we just hoped that people would get it, as we've said, and it's been such a long journey.
It's been a hell of a journey, hasn't it?
Yeah.
But I think for all of us, it's a process of reviewing what in nearly all our cases has been a kind of life's work in a way. And sometimes a life's work filtered through very profound and difficult life experiences. So it's been enormously satisfying, I think, in the end, to come up with something that feels like it kind of validates everything that led up to it.
This new framework is a way of saying we are now taking on board both the criticisms but also providing alternatives about causes and meanings, because causes and meanings in human life are important, whether or not you've got a mental health problem. So this is just a way of doing it, which doesn't involve any longer putting people in diagnostic boxes which have been invented by professionals.
We're very keen that this was a framework which is essentially offering people an alternative to the traditional diagnostic framework, which of course some people have found helpful, and we acknowledge that in the document. And but you know, myself and many other people have found that having diagnoses imposed on us and no alternatives being offered, actually, well, not just unhelpful, in sometimes actually really traumatizing. Have kind of very real things just turned into symptoms and then medicalised.
I think for me the absolute key message is that distress happens from the outside inwards. That for me has been my guiding principle with this, with all my thinking about the project and all the ways the project is developed. It's to get to an understanding of how it is that people who experience difficult life events or unusual combinations of adverse circumstances, how distress happens for them in ways that doesn't hold them personally responsible or culpable.
I think this framework is really welcome, and it's going to substantiate and provide so much more richness and explanation to some of the things that social workers have known for a very long time, some of the models that we work to. It's going to enable us to have discussions across the different professions about how we can come together on a different way of understanding mental health illness and mental health problems and mental distress.
And it's delightful to see 400 people here today to celebrate this very important step forward.
Well, I think, like we've said today, one of the things about this kind of framework is really trying to make sense of what is often seems quite surprising, unusual kinds of experiences that can happen to people when they feel distressed. And I think what we're trying to do is try to provide a framework for making sense of that and making links between what's happening for people and what's happening in their lives and what's happened in the past as well.
It's just that kind of real lived experience that is really coming across very powerfully. And for me, I place a lot of value in people with lived experience being in control of, you know, how their stories are told, but also what kind of responses most make sense to them.
People are really hungering for alternative ways of making sense. So yeah, it's fantastic.
You know, really, I found the day really useful. I found all the presentations, you know, funny, enlightening, really made me think in a different kind of way. So I'm really quite excited about the future.
It's been fantastic. It's really exciting. I think, you know, we live in an era of austerity where it often feels like everything's going downhill. There's more and more difficulty, less and less resources, and so this is, you know, it's great to hear an idea about hope, really, and new ways of looking at things.
So now I'm going to talk in a bit more detail about the framework. This is there's quite a lot of words and talking, I'm afraid. So if you can bear with it, after lunch it'll be a whole lot easier. But we will stop in time for questions before we have lunch. So the framework, as I've said, is narrative-based, and the framework suggests this loose structure for creating or co-creating narratives. Now, narratives can work at any level. They can be a one-to-one personal narrative for a particular client. They can be a narrative for a team, for an organisation, for a social group, for a whole culture, in a way. And narratives, the idea is this is not another form of assessment. It's not about what happened to you, tick, how did it affect you, tick. These are suggested areas to think about. And you don't have to use these words, you don't have to use the questions in this order. These are adaptable questions. But because the framework is so long and complicated, it seemed to us to make sense to summarise it in this set of core questions. It's a kind of hook for the rest of the framework to hang on, if you like. So the whole framework, in a way, is an expansion of that core question. Instead of asking what's wrong with me, ask what's happened to me. And we've added what happened to you, we've added some questions onto that. So we start with what happened to you, and in framework terms, that means how is power operating in your life? We then move on to how did it affect you? In framework terms, what kind of threats does this pose? The next question is, what sense did you make of it? In other words, what is the meaning of these experiences to you? What did you have to do to survive? What kinds of threat responses are you using? And you might want to add or start with, what are your strengths? In other words, what access to power resources do you have? And to pull it all together, what is your story? So you can actually start at any point. You might, for example, people typically come along saying, I have this panic, or I feel so low and miserable, so that'd be a threat response. You might want to start there and work backwards. And you will find that these questions are overlapping. So it's a circular process in a way. You revisit the questions, you go over these areas, and you gradually build up a picture of a story, which is never ended in a way. There's always an ongoing story of people's lives. So I'm now going to go through the questions one by one. So what has happened to you? You don't need to read all that language on the slides, but we have put power first and foremost in the framework, because it's the aspect of thinking about people's problems that is missing by definition from diagnostic thinking, which is telling you the problem's inside you, or perhaps inside your brain. It's also missing from a lot of psychology and psychotherapy. So we wanted to start, at least in the document, with power. So we have a very, very long chapter in the main document about the various forms of power, which are listed there. Legal power, economic power, interpersonal power. That's to do with a lot of the area that trauma-informed practice covers, the various ways people can hurt and abuse and neglect and humiliate and exclude each other and so on. Power by force, the power of our bodies, our talents, our limitations. Social or cultural capital, which is a form of power we're less used to thinking about. So think back to the diagram of the tree in trauma-informed practice. A lot of the people who suffer the worst adversities are people who have very little social or cultural capital. They are not born in a world where things come to them easily, where they necessarily know their way around the world, where they're confident to challenge organisations, where they can get a good education. There are all of those subtle aspects of power that I'm a good example of someone who's benefit from a lot of that. I have a good education, I come from a reasonably comfortable background, but a lot of people in services do not. So we need to consider those forms of power, and also the fact that if we give someone a psychiatric diagnosis, we're often giving them a further barrier to that kind of power. Harder to get employment, harder to feel good about yourself, harder perhaps to make relationships. And ideological power, which is a very important part of the framework, which I will discuss in a minute. So why is power so central in the framework? Because it's everywhere, even perhaps especially when we're not aware of it. And actually, we know this. What we know very well from all the evidence is that all the major causes of what we might call mental health problems involve inequalities of power. Poverty and low social status, large differences in wealth or income, child abuse and neglect, gender-based and race-based discrimination, violence, colonisation, war and conflict. These all arise from conflicts between more powerful groups and less powerful groups, which are listed there. Now, this is not in doubt. There's a mountain of evidence to show this, but we don't act as though that's true, do we? Those are not our research priorities. Those are not the areas we try to address. Those very often aren't the things we actually talk about with people. So we wanted to put power right back in the centre in the framework. That is the main way of linking personal distress to wider contexts. And we particularly wanted to talk about ideological power, which is a more subtle form of power. We've defined it as control of language, meaning and perspective. And this covers things like the things we assume are automatically true or desirable or valuable, our worldviews, our very core beliefs, which may seem to us just the way the world is or the way the world should be, but actually they're not necessarily natural or facts. So these kind of assumptions are built up in various ways. Partly we are told about stereotypes of certain groups. Refugees are like this, women are like this, men are like this. People from certain ethnic backgrounds are like this, and so on. And these worldviews are sold through language as well. And we've had a lot of example of this in the UK, of course, since we had Brexit, which was obviously going to be a disaster and is a disaster. This was sold to us partly by language. We were told about a swarm of migrants who were going to overwhelm our welfare services. We were appealed to our sense of pride. We're going to take back our sovereignty, our control, like we're still heading up an empire. I mean, it's ridiculous and damaging. And in that case, and in many others, ideological power often operates to the advantage of more powerful groups. Some people have made a great deal of money through Brexit, and to the disadvantage of less powerful groups. People who are worse off have even less than they had before. So we need to be careful about these subtle forms of power. They're very hard to unpick. Okay, so the use of language shapes how we make sense of our experiences. So if we tell someone who's been raped, she asked for it. If we describe people who are living in poverty as welfare scroungers and so on, we are using language to blame the victim, if you like. And the same thing happens in psychiatric services. People suffering from the impact of very severe trauma may be told they're psychotic, personality disordered, mentally ill. Now, working in services, we may think and genuinely believe and have been trained to believe and practice with the idea that that's just a fact. They have a mental illness called this. From the framework perspective, we see that as using language as a form of ideological power. So the mental health and criminal justice system are involved at a very core level at turning social problems into individual ones via the use of language. This is an imposition of power. The imposition of a diagnosis is an act of injustice, in our view, which of course can lead to further abuses of power. You may be held down, injected, or all sorts of horrible things may happen to you. So I always say this to groups of mental health professionals, and nobody's contradicted me yet, but it usually leads to a kind of slightly uncomfortable silence, perhaps, because these are difficult things to talk about and difficult ideas to bring up. And I, too, have been part of the mental health system for many years, and so we've all been part of this. And psychiatry is required to perform this role by society as a whole. Mental health professionals are just one layer of that. Use of psychiatry in many cases to exert control over people, to in effect label the casualties of our society as suffering from mental illnesses. When we focus on power, it's much harder to change what's happened back into what's wrong with you. It's much harder to individualise problems because power links the personal and political, links distress to inequalities and injustice, links the social, psychological and biological, makes distress understandable, and helps to restore agency, the sense that you can do something to change your life. Okay, so that's the first question. Working one-to-one with someone, you'd probably work backwards to that quite slowly. You wouldn't plunge in and start with power, because by definition that's going to be the most difficult stuff. But you would be starting from the perspective that some of this is bound to be relevant. How did it affect you is the next question. Because these are overlapping questions, this sort of follows automatically from thinking about power. And power can affect us in all sorts of areas of our lives, some of which we're used to thinking about, some of which we're not. So relationships, our emotions, our ability to manage our emotions, our links to the community, our economic and material security, our environment, our bodily health, our value base and our meaning making. And this is something we're less used to thinking about. To what extent do we encourage people to construct their own meanings and values, to challenge meanings and values, including diagnostic ones that have been imposed on them and that may not be useful to them? Okay, what sense did you make of it? So all therapies are in a sense about making meaning out of people's experiences. And all human beings make sense of their experiences as part of what we do. But what do we mean by meaning? It seems to us that a lot of the discussion about meaning that happens in therapies, in services, happens at too narrow a level. We talk about people's thoughts as though they just arose inside their heads. Perhaps in cognitive behavioural therapy, we challenge their negative schemas or whatever. And we don't very often think about where those meanings come from. We need to trace those meanings back, not just think of them as individual examples of the belief that someone happens to have. So meanings are never just personal, individual. They are never just freely chosen. We make our own meanings, but we base that on the meanings all around us. And so meaning making through narrative, but meaning making at all levels is a very core part of the framework. So where do our meanings come from if they don't just come from inside our heads? Well, they come from all sorts of places. They come from the language we hear about us, the things that we hear talked about in society, the things we mean by saying someone who's successful or a good mother or a happy family or a normal child. All these ways of thinking, which are all around us all the time, carry meanings which we take on as individual. And as I've already said, all of these are likely to be shaped at some level by ideological meanings. So many of our social meanings in Western contexts are shaped by our current economic systems, which support certain values about consumerism, buying things, having a nice lifestyle, competing rather than cooperating, seeing ourselves as individuals rather than members of a family or member of the group, and so on. So these are deeply embedded ways of thinking in westernized societies that serve certain economic interests ultimately, but may not serve us best as human beings and as a social group. And when this fails to work, then in a consumerist, in a materialist society that's driven on economic profit, we may be encouraged to buy more solutions, buy and sell drugs, therapies, material possessions, lifestyles, change our bodies, and so on. So it's a complex process. So the example I often give is that in my last job, I and my colleagues set up a series of groups for women who are survivors of rape and sexual abuse. And we did a lot of good work, I think, very similar to what you might do one-to-one. So every single one of these women came along saying, I feel ashamed, it's my fault, I feel to blame, I feel guilty, I feel dirty, I can't tell anyone, and so on. So those are very common meanings, but what is unusual is that I've probably worked with several hundred women who all come along saying the same things, the same meanings. I feel ashamed, I feel dirty, it was my fault. So where do those meanings come from? Hundreds of women all keeping quiet about it, and they've all got the same meanings. Well, obviously those meanings come from roundabout, don't they? They come from all the messages we get about sexual assault and women's bodies and men and men's responsibility, and our whole reluctance as a society to recognise the widespread extent of violence and sexual violence, particularly in women's and girls' lives. So in a group, what you can do is you can go beyond I feel ashamed and I'm going to try and feel better about myself, to think together about where did these meanings come from? How did we get these messages? In whose interest are those messages working? How come we fell for that trick? We don't have to do that anymore. So it's a very powerful way of putting responsibility back where it belongs. It kind of goes beyond what you would usually do in individual therapy, but I think it's the kind of thing that the framework would support. And that's not new. You know, in the 70s, it was called consciousness raising, and women did it in women's groups. It's not new, but it's important stuff. And of course, there are equivalent, dilemmas for men, and the very unhelpful messages that are often sold to men as well. So what that did for these groups is, at least for some women, they went beyond recovering and actually were able to take some kind of action, set up a self-help group, join us as members of staff alongside us as equals to train other staff in working with abuse and trauma. So for some people, they will want to create what Jackie Dillon has called a survivor mission. It's a way of going beyond healing, if you like, to say, I want to make some use of this experience to make life better for other people. Okay, and what did you have to do to survive? These are threat responses. So this roughly covers the areas of what we might call symptoms, but in the framework they are threat responses or survival responses. So this part of the framework draws quite a lot on trauma-informed practice, and it draws quite a lot on what we know about the impact of trauma on our bodies. The framework is not just about our minds, it's about our bodies. Our bodies respond to threat. The whole separation of mind-body is a particularly Western way of thinking in itself, isn't it? It doesn't hold in all cultures. So the framework is about all of us, mind and body. And here's some examples of threat responses. Some responses are more experienced at a bodily level: fight, flight, flee, overwhelming desire to flee or overwhelming anxiety. We have relatively little control over that. That's our bodies automatically reacting to what they perceive as threat. But if we go down the list, we find that there are threat responses that we have to have perhaps a little more conscious control over. So, for example, we may use alcohol or we may self-harm. It may be very difficult to stop that, but it's not out of our control in the same sense as a bodily threat reaction is. And down the bottom, you can find that actually a lot of the things that are socially valued, and so no one's going to call that a symptom, can actually be seen as threat responses. So those are two of mine. I work too hard and I'm too much of a perfectionist. Those are very much values that are promoted by the society I and we live in. So people are going to pat me on the back for that. They're not going to say that's a sign of a mental illness. Nevertheless, I know that for me that's sometimes a threat response and not a particularly healthy way of living. Okay, so making the link between threats and threat responses. This is one of the main purposes of the framework. When we give someone a psychiatric diagnosis, we obscure, we sever, we cut the link between the threats and the threat responses. And we go off and try and treat the threat response or the symptom. But the framework shows how we can restore the links between threats and threat responses. And another way of saying the same thing is restoring the links between personal distress and social or political contexts. So this is a very odd thing, I always think, because it's kind of common sense. An awful lot of the framework is common sense. Because we all know that people living in poverty are more likely to feel miserable and desperate. Is anyone surprised about that? The research shows it, we can call it depression, but it's not surprising. We recognise that young people under pressure from educational goals and social media messages are likely to feel worried. But at the same time, we start thinking and talking. As soon as we know that, we start talking about an epidemic of depression, as though it's arisen from nowhere, like COVID, and we start talking about new pills to treat it. So we can hold these things together for 1 minute, and then as soon as we start thinking diagnostic language, we lose that link. The link is concealed from the person themselves. They start to think, I've got a mental illness. It's concealed from us as professionals, and it's concealed from society as a whole. So here's a couple of examples. We had a lot of these articles in the UK press, you probably had similar ones, about COVID-19. Mental health services must be boosted to deal with a tsunami of cases. That tsunami, a tidal wave, an epidemic of cases after lockdown. So that all sounds very worrying, but if you look at the people who are most likely to suffer what is called mental health problems after COVID, they're actually the people who had most problems in their lives and were all probably already struggling. So they're older people, they're people at risk of domestic abuse, shut up with their partners, they're people with very little money, so their jobs are very insecure, they're people whose health is very poor, they're women who are trying to work and look after children, and they're frontline workers who are burnt out. So it is absolutely not surprising that those are the people who struggled most. And what COVID actually did in the UK, and I imagine elsewhere, is to expose the vast inequalities in our societies. So almost all minority ethnic groups had higher risks of dying from COVID than the white British majority of a comparable age. So the message to draw from that is really not hundreds of extra counsellors, therapists, nurses, doctors, psychologists. The message is look at the inequalities that are exposed in people's lives and deal with those. But that's not the message we're getting in the press, and a lot of very interested parties, like professionals of various backgrounds, are rushing forward saying, yes, you need more people like me. Okay, so here's an article I wrote about it. In ordinary language, people with more to be exhausted, depressed and anxious about are feeling more exhausted, depressed and anxious. It is not a pandemic of mental health problems we need to fear, but a pandemic of mental health thinking. It's mental health thinking that the framework really seeks to challenge. So this is an article that went to, it's a journal that goes to every psychiatrist in the UK. And one of them responded, who's a friend of mine, and said, this is the best thing I've read about COVID. And another responded and said, this is complete rubbish. And everyone else kept quiet. So that was interesting. Here's another example, disconnecting threat responses from threats. We've already talked about young people quite a lot. Rate of mental disorders among 17 to 19-year-olds increased in 2022. This report, widely publicised in the UK, 1 in 4 17 to 19-year-olds in England had a probable mental disorder. That doesn't sound too good. Look at the evidence. The people with the probable mental health disorder were much more likely to have been bullied, feel unsafe in school, lack friends, be worried about exams, living in a family that couldn't afford to buy enough food, fallen behind with the rent, bills or mortgage, couldn't afford to keep the house warm. Those young people have not suddenly developed mental health disorders. They are very worried for very good reason. And the cure is not more labels and pills. The cure is for families to have enough to live on and children to feel safe in schools. But you can see how that discourse, it lets society off the hook, doesn't it, entirely? Lets society off the hook. Okay, here's another example. I will read this because it might not be very easy to read. This is from one of our daily papers. I thought this was a very interesting story. Why are so many clever, privileged teenage girls on antidepressants is the headline. So this addresses the issue that's come up quite a number of times, I think. Not everyone who's distressed has a kind of trauma as such. So this is where the framework helps us to go beyond trauma-informed practice. On paper, Ella would seem to be the envy of many young people her age. She is slim, attractive, a gifted dancer with hopes of studying drama at university. She comes from a secure, loving family with professional parents and 2 siblings with equally rosy prospects. But following an attempt to end her life last spring, she's been on medication for depression for more than a year. It came after 6 months of therapy, which failed to halt the intrusive thoughts that plagued her. Thoughts that she'd never be pretty enough, never be popular enough, never be clever enough. She said, the pressure of trying to keep up with everyone else never stops. I never feel good enough. I go onto Instagram and see my friends meeting up together, and I think, why aren't I there too? I see boys commenting on pictures of girls at school saying how hot they look, so I think I have to look like that too. Girls lie about their exam marks because everyone's in competition. Ella's mother said, Ella said she hates herself and I don't know why. There's nothing wrong with her. She's beautiful and wonderful. So I find that a very heartbreaking story, really, and it's a very typical one. So we can see that Ella has had the individually focused treatment. She's had the pill hasn't worked. She's had the CBT, challenge these thoughts, that hasn't worked. But she's been bombarded with messages, incredibly damaging messages, ideologically driven messages all around her. So of course that doesn't work. Of course that doesn't work. These are the horrendous pressures that young people are facing, and it can really only be tackled, well, at a much more group level. You know, maybe schools need to be getting young people together to challenge, identify and challenge these messages as a group, but we also need to be challenging all this as a society. These are the messages. There are more extreme versions of the messages we're all encouraged to live up to, aren't they? Look like this, achieve like this, have this kind of lifestyle. Okay. So I'm going to talk very briefly about a couple of other aspects of the framework. So, excuse me, we have, as well as showing how you can put together narratives, might work at a one-to-one level or a team level or a social group level, we've also tried to outline what we've called general patterns. This follows on from what I've said earlier, that our particular stories, let's say someone who has been raped and her story about herself is, I'm ashamed, I'm guilty, it's my fault. Let's say that's her story about herself. Those messages don't come from just inside her head, as we said. They come from general narratives that are available, that are around, that are pushed on us from a whole society. Yep, so her particular story, feeling shame and guilt and so on, is part of a general story about how women ought to feel if they are raped or abused. So we've tried to put together these kind of patterns that work at a kind of social level. They're meta-narratives, so each personal narrative is a particular version of that bigger overall narrative. And importantly, these patterns describe what people do at some level, not what they have. So this is one of the big leaps we eventually made in our thinking, a diagnostic narrative, because a medical narrative is a form of narrative, but it's about what you have. I have this illness, I have this condition. A framework narrative is about what you do, in a sense. I feel like this, and this is how I survive it. Okay, so here are some examples. If you look on the website, we've actually got some new examples up there. So these patterns are evidence-based. What we do is look at a whole range of evidence about the impact of, let's say, bullying as being bullied as a child, and we put that together in framework terms. So there are common narratives, common stories, common sets of experiences for people who have survived bullying and people who are living in poverty. So as I've said, there are always individual aspects to a story, but there are also always shared aspects. And a lot of people say, well, a diagnosis helped me to feel better about myself because I realised I wasn't on my own. Other people feel like this. It's not just me. It's not my fault. Well, we think that these patterns can serve that same purpose, but serve it better. Because reading a pattern, if you were able to say to someone, your feelings of shame and exclusion are so common, there's actually a pattern that describes them, could have the same benefits of showing people it's not just me, it's not all about me, and actually I can trace back where this narrative comes from for me and for everyone else who may be in a similar position, which is what we did in the sexual abuse survivor groups that I described. So here's one of our recent patterns on the website. It's about surviving poverty. Again, I would like to emphasize these are evidence-based patterns. They didn't just come out of our head. So each of the patterns has got a power, threat, meaning, threat response, and strength aspects, and a summary. So poverty, for example, you don't need to read all this. Lack of economic power affects access to housing, transport, heating, food and clothing, holidays, leisure opportunities and medical care. Poverty also means you are exposed to the negative operation of almost every other form of power. You are likely to be experiencing threats to almost every area of your life. Your meanings are likely to include, I feel overwhelmed, I feel humiliated, I feel excluded, I feel ashamed. Those are meanings that can be challenged, perhaps, when you see the bigger pattern, so that I don't have to feel personally ashamed, personally excluded. In the little yellow book I showed you, we have some examples of people's stories and people being able to look at patterns and say, that's a relief, I don't have to think it's all me. And there will be different threat responses, use of alcohol and drugs, for example. Now, not recommending use of alcohol and drugs, but if you put that in the context of a pattern, it becomes understandable. One of the ways in which we hope these patterns are going to be used, and have started to be used, is in public health. So if you look at a whole population and saying, well, there's too much use of alcohol, then this kind of approach will help you, we think, to look at the actual roots of that, instead of saying just we need more education about the effects of alcohol. Well, people know that, but people are relying on alcohol in very difficult situations for reasons that actually need to be dealt with if we're ever going to reduce misuse of alcohol. Okay. Can't remember what slide is next. Okay, so just going to add something to the pattern, as the patterns are kind of complicated. They're complicated to get your head round, and they took us a while to get our head round, to be honest. So just going to give you a bit of the theory. You can tune out if this bit isn't of interest to you. But in general medicine, what do we mean by a diagnosis? Say you give someone a diagnosis of diabetes. What you mean is that medical research has established a pattern of things that can go wrong in your body, things that can go wrong in your pancreas that affects the production of insulin that leads to symptoms like thirst and losing weight and so on. So a diagnosis in general medicine is really a way of saying we have found a pattern and we think you match this pattern. Does that make sense? So that you go to your family doctor and say, I feel thirsty and I've lost weight and all the rest of it. They might say, we think this is diabetes. We think this matches a pattern that's based on evidence, based on medical research. We can do some tests and see if you fit that pattern. So that's how it works. And in lots of areas of medicine, that works very well. So the diagnostic system in medicine is really about pattern identification. So our dilemma in the framework was, what kind of patterns are most useful and appropriate, not for what goes wrong in your body, but for what goes wrong in your life? And after a lot of thinking, we came up with this answer, which is that these patterns, instead of based on patterns in the body, need to be based on patterns of meaning. So the general patterns are, in a sense, patterns of meaning at an individual and a group and a social level. And because they're patterns of meaning, they are not and can never be as precise as patterns of what goes wrong in your body. Meanings change over time. They change across cultures. So they're shifting patterns. They're like currents in water, if you like, not like this box versus this box. So the patterns are not about fitting people into a new form of box. That's a common misunderstanding. They are about identifying narratives that maybe have affected you and may have shaped your personal meanings. They're a very, very different form of pattern, but they are a real and important form of pattern. So it's only when you can identify patterns at a broad level that you can start to claim maybe we've actually come up with a different conceptual framework, not just a new way of treating this or a new approach or a new project. All of those things may be useful if you want a completely different conceptual framework to the diagnostic one, you have to have an alternative way of constructing and identifying and describing patterns. Does that kind of make sense? Now, it's not perfect, it's evolving. I don't think we got it all right, but that is our principle and our intention. Patterns shaped by meaning. They include our bodies, of course, but they're fundamentally shaped on meaning. Okay, so that's the patterns. That is the most complicated bit of the framework. Okay, going to talk about another aspect of the framework and what we might call culture. So we've touched on this already. We talked right at the beginning of the morning, all that time ago, about how diagnostic understandings are being exported across the globe, often very damagingly, in my view, often to cultures and countries that have their own ways of healing distress and don't need our failed model. So, what does the framework have to offer to cultural understandings? Well, the framework was written and produced within a particular Western culture, largely entirely by people brought up within that culture, many of whom are white. So the framework is not saying, we've got something that we can export to other countries and cultures instead. We're really not saying that, because in a way we're saying all understandings of distress have to be, to some extent, culturally local. Meanings change, cultures are different. If all understandings and expressions of distress are culturally shaped, there isn't going to be one version that works across the whole world. But what the framework can say is, our way is no better than your way. Your way works in your context, and this includes minority groups within the UK, of course, as well as different countries and cultures around the world. We can respect and learn from your way. It may work very well in your setting, and our way may be more appropriate in our setting. And as I've already said, some of the indigenous ways of healing that survive are, interestingly, often narrative and community-based, which is something the framework argues for in every setting. So the framework wants to go beyond trauma and adversities of the types we've talked about, to think about histories of colonization, slavery, intergenerational trauma, the resulting discrimination, loss of identity, culture, heritage, and land. We don't usually think about those. It's very well established, for example, that just about every single indigenous group in the world has very high rates of so-called mental illness. Well, I wonder why that is, because they've almost universally suffered extreme loss of culture, heritage, language, and land. The framework respects views which see individuals and groups as inseparable, part of each other, and which highlight the relationship to the natural world, which aim for the integration of mind, body, spirit, and natural world. These are wisdoms we've lost. We have a lot to learn from wisdoms and from cultures that have retained some of these forms of knowledge. And to respect and support culturally supported practices, community narratives, values, faiths, and spiritual beliefs. Okay, so I'll read this out in a minute, but one of the most interesting things I've done in my entire career was that I was invited with one of the co-authors to do a tour of New Zealand and Australia with the framework in 2019. And so I did. I started in Auckland in New Zealand, and I had asked if we could have 2 days. One day was me presenting the framework, and I wanted some Maori and Pacific Islander people to be in the audience, Maori being the indigenous people of New Zealand, of course. And the next day, we presented, or rather they presented, Maori understandings of distress. So it was an absolutely fascinating 2 days. The idea was sort of do a sort of compare and contrast. So I did my rather PowerPoint-heavy presentation on the first day, managed not to put too many people off, I hope. And it was held in a Maori meeting place, and so there's a lot of ritual associated with that. You have to kind of thank your ancestors and welcome people with a song and so on. And the second day, there were the Maori presentation, which again started with singing and chanting, and it was about 1 million miles away from a PowerPoint presentation. Maori understandings of distress in terms of the Sky Father and the Earth Mother and the gods, and the relationships they have with each other and the fights and the adventures and so on. So their way of healing distress is to come together in a group, and they have groups at several levels, extended families and groups including your local tribes and so on, and to share these stories together and to work out whether any of these stories make sense to the person who seems to be in distress. So it's about as different from diagnostic practice you could get. It's also pretty different from the framework. But interestingly, as the 2 days went on, and the Maori people were very interested in the framework, which was great, what we discovered was that at some level there were similarities. We were both talking about narratives, although talking about them in very different ways. And in a way, we were both talking about narratives of power, threat, meaning, and threat response, because that's what the stories of the gods are fundamentally about. These are universal human experiences and struggles. And that particular way works very well in Maori culture. And interestingly, there are clinics set up in New Zealand where you can request to go and have a Maori understanding of distress. So you turn up with your extended family and you go through this process. It's a very enlightened place, New Zealand, as you know, and I probably should have stayed there. Anyway, it was really, really fascinating, really fascinating. One of the interesting things that happened on the first day was that I was trying to explain what a formulation is, and I was thinking, how is this going down with Maori elders? I don't know if this makes any sense. And one of them put up his hand and said, so you're saying a formulation is when two people are in close contact and they touch each other's hearts. So I found that a really moving thing to hear. That's not in the official definitions of formulation in all the books I've written about it. But that's it. That's absolutely it, isn't it? It's about sharing each other's meanings, touching each other's hearts. So this slide, after I came back from New Zealand, I wrote a joint article with a Maori psychiatrist who was one of the people who's been setting up these clinics. She says, the publication of the framework was a welcome relief for me at a time when I led a new service. Our attempt was to revolutionise the way in which services are shaped, to centralise meaning, values, culture and relationships, making the medical model secondary. The framework supported our belief that there was a need to challenge the status quo. The framework has acted as a distant cousin with more commonalities than differences. I really like that phrase, distant cousin. We're part of the same human family. We're distant cousins. So she doesn't use the framework explicitly in her clinic, but she found it helpful to refer to the framework to say, this supports my argument that we need culturally appropriate ways of understanding distress for Maori people. So there we are. That was very interesting. So, storytelling and meaning-making universal human skills. The AIM framework provides evidence of the central role of narratives of all kinds as an alternative to diagnosis. Narratives are a means of witnessing and healing both within and beyond services. There are many valid forms of narratives. The framework promotes the restorative part of truth-telling. Recovery is a process of reclaiming our experience in order to take back authorship of our own stories. Okay, I'm going to stop in about 5 or 10 minutes to have some questions, but I just wanted to put up this slide because, as I've already said, in the framework, we've referred to the open dialogue as a good example of one way of translating framework ideas into practice. And there are similarities and differences, so I just thought I'd summarise them in this slide, and you may disagree. I mean, I'm not an expert in the open dialogue, but I suspect open dialogue is going to come up in our subsequent discussions. So the framework and open dialogue, a difference is that they're developed at very different levels. So the framework is a general set of principles applicable across multiple areas, and open dialogue, of course, has very specific ideas and strategies and skills for working in clinical services, but they're complementary. I think they fit together pretty well. What could open dialogue offer the framework? Well, I think open dialogue practitioners have done I know they've done a huge amount of thinking about what we mean by narrative. They've done a lot of training in narrative practice. They're an excellent example of system change, and it has research evidence to support it, of course. What could the framework offer an open dialogue? This is only suggestions, possibly an additional emphasis on power and all its forms, possibly an additional emphasis on the societal, cultural and ideological roots of dominant narratives. Not all narratives are equal, as we've been discussed. Some are supported by massive power interests, some are dominant, some are very much forced on people, some are pushed out of the way. Support for non-professional narrative construction, because the framework isn't just about clinical work, and a very explicit challenge to diagnosis, which I'd be interested to hear about that, but as I understand it, isn't a kind of upfront feature of open dialogue. It's something to discuss, but doesn't suggest such an explicit challenge. Okay, so that's for this afternoon. I want to give you a couple of examples very briefly. Okay, so since publication in January 2018, lots has happened. Won't go through all that. That's a list of talks we've been invited to give and conferences we've done keynote speeches at and so on. All of those are quite well-known conferences in the UK. And we've done various tours of other countries, and there are translations around, as I've said. So I want to give you a couple of examples of what it might look like in practice. It's all been a bit theoretical so far, hasn't it? What might it look like in practice? Some of you here are going to be around tomorrow, I think, where we're going to do a workshop, much less talking from me, much more how might this work in practice. But I'll give you a flavour for those who won't be there. Okay, so one of the things that we're pleased about is that some peer groups, so groups of people who are receiving or have received psychiatric treatment and who get together to support each other without professionals, have come across the framework and decided to use it. In both cases that I know about, actually, they decided they'd meet as a group every week, as they usually do. They'd take one question each week: what has happened to you? What sense did you make of it? And so on. Share their thoughts and see if they could together come up with different stories. And as we can see from the quote from the article, which is on the website, that Amanda Griffith, one of the people who leads a peer group in the north of England, did this and found that this helped her on the road to becoming a strong, independent survivor, taking control of my life. And she generously decided that she would share her experience of putting her story together as a PTMF narrative. Now, can you see that from the back? Can you read that? Do you want me to read it out? Wave at the back if you can't see a word of that. Okay, I'll assume you can read it. My voice is running out, so if you could have a quick read of that. This is Amanda's understanding of her experiences of power abuse. And as you can see, she's someone who had a great many traumas in her life, was re-traumatized by services, and was given a label of personality disorder. You can have these slides afterwards, as I said, so don't worry if you can't read every word of these slides right now. So she's had a great deal of trauma and adversity in her life, including being re-traumatized by services. And as I say, you might not have time to read every word of this. That has, of course, led to a lot of threats, flashbacks, dissociation, silencing, feeling angry, anxious, physically exhausted, and occasionally feeling suicidal, which is not surprising when you know about the threat experiences she went through. Okay, and the meaning she took from this, sadly, but perhaps not surprisingly, were that she's a worthless person who's undeserving of help and treatment. There's something wrong with her, she deserved to be hurt, the world is unsafe, I would be better off dead. I hope some of those meanings have changed a bit since, but at the time she put together this story, that those meanings were the ones that she held. And I think I would say that a lot of the messages of the psychiatric system probably reinforce that. Threat responses, here's a list of threat responses which are not surprising when you know about the power and the threats. So she's constantly watching out for people who might hurt her, avoiding situations, feels often very aggressive and very scared in relation to other people. She controls her food intake. She sometimes uses alcohol to block out the pain. The threat responses are not symptoms, they are completely unsurprising attempts to survive the threats. And she's also able to acknowledge that she has a lot of strengths. This is the bit you don't get from a diagnosis. She knows a lot about psychology. She's intelligent and resilient. She can stand up for herself. She has good relationships with her peers. She's learning new skills. She's met some very good professionals, some trauma-informed professionals, who have helped her to understand her problems differently. And she has a lovely family who give me the strength and determination to get through each day. And this is how she puts it together. Adverse childhood experiences led to complex trauma throughout my life. Constant repetitive cycles of coercion, powerlessness, and multiple forms of abuse have not only had a lasting effect upon my interactions with others, but are impacting my physical, emotional, and psychological well-being. My energy levels are depleted from being constantly broken and distressed by a disempowering, authoritative and controlling mental health system that has been coercive and traumatizing when I needed trauma-informed care. As a consequence, I'm dispirited and I struggle to trust others, and so on. But my relationships with my peers and family are protective factors that motivate me to find the strength to self-educate. I campaign for trauma-informed services and improve mental health provisions for other survivors. So you can see that's a very different story from I have a personality disorder. It's a very different story. It's not an easy story, and it's a story of an ongoing struggle, but it's a much more hopeful story. And I'm delighted to say that Amanda has now joined the group of trainers in the UK who offer training and talks in the framework. She's an excellent trainer. I've done a lot of training with her. She's done a lot of training herself. We want to work with survivors to offer this kind of introduction to the PTM framework. And since she put together her story, she hasn't needed to go back into hospital. So that has to be a good outcome. Okay, I'm going to show you two more very brief examples. Promise they're brief. So you might not be able to see this, but this is on the website. All this stuff is on the website. This is an Irish charity called Jigsaw that works with young people aged 12 to 25, and they have taken on the framework in quite a big way. And what they've done is rewrite the questions with their young people so they make more sense to young people. So instead of what happened to you, how's power operating in your life, that's not a very easy form of question for lots of people. They've come up with these fantastic worksheets. So this is about ideological power. It's pointing towards diversity. It's pointing towards identity. It's pointing towards other aspects of ideological power. So these are worksheets you can use with a young person to work out what's going on in their lives. So all on the website, all free to use. Okay, and my final example, you'll get these slides, that's the link to those resources and a link to a blog written by one of the people who works at Jigsaw. The power of the unveiling of some of these truths in the room with people, it's just so palpable. I can feel it in a way that I could never feel with giving a diagnosis or engaging with a CBT program. You're not telling them the answers, you're uncovering the answers together. So we've talked a lot about young people so far, haven't we? How can we give them a different narrative? Jigsaw is a very good example of helping young people to have a different narrative. And they don't refuse to talk in diagnostic language if that's what young people want, but they do offer the opportunity for a different non-diagnostic narrative. And finally, okay, so this is an example of some inpatient wards in central and northwest London. I've been offering supervision to this team of very dedicated professionals for about 5 years. They started in 2017 with a very narrow focus on diagnosis and medicine. They had low staff morale. They had lots of don't know what you call them here, coercive interventions, people being put in seclusion, being held down and injected on the ward. And things were going very badly. Very briefly, they've done a lot of work introducing both trauma-informed practice and the power threat meaning framework. Those two things go together pretty well. A bit like open dialogue and the framework, I think, go together pretty well. So briefly, what they've done is they've developed a lot of trauma-informed manuals, which are free for anyone to download and use. They're in English, of course. So every person who comes onto the ward has a chance to discuss regularly with their main worker what are the impacts of trauma and adversity, how are they showing themselves in your life, how might we help you to manage some of these very distressing feelings. So these are a way, people who know about trauma-informed practice will know about this. This is the first stage before going into any discussing of trauma itself. It's about learning to feel calmer in your body, to manage your anxiety, to feel safer in the world, and so on. So that's part of the treatment for every service user who comes on the ward. And they also have regular meetings on every ward where they discuss each of the inpatients on the ward in terms of putting together a power threat meaning framework narrative. So the staff group gets together, they think about that person's history, they think about what the stuck points might be, where does this person seem to be struggling. They go through power, threat, meaning and threat responses. They put together a story which then forms, which is shared with the person, of course, which changes over time, which forms the basis for the way forward. So staff interviews. The framework has helped us to understand our patients as individuals and address what's behind the diagnosis, not the diagnosis itself. And service users, I think it makes a real difference on the ward. For the first time in a very long time, it's given me purpose and hope. Dramatic changes over 4 years, dramatic reduction in self-harm, in restrictive interventions, better staff morale, service users saying they're getting a much better experience of services. This article has just been published just this week. It's summarised on MAD in the UK and MAD in America today, I believe. Nobody's attacked it yet. They haven't quite worked out how to do so. I'm waiting to find out what the attack is. But I mean, if any new drug achieved these kind of results, everyone would be on it tomorrow, wouldn't they? So again, there's lots going on these walls that's still very standard and traditional. The framework is running alongside that rather than completely replacing it. But I think it does show in very medical settings, which London inpatient wards are, you can introduce real change. And this project is now running on all 14 of their inpatient wards. So that covers covers several million people. They're part of London, probably equivalent to about half the population of Norway. So, I've slightly overrun into question time, but that's everything I have to say before we have some questions. Thank you for listening so patiently. I suppose I address one or two of the questions that have been submitted, which we didn't get around to. So, one of them was something like, how have you found it talking to clients about diagnosis and whether or not it's a valid thing to do? I think that was one of the questions. My simple answer to that is that I have not found that a problem. So I do very strongly believe that people have the right to describe themselves in diagnostic terms if they want, if that makes sense to them. Of course, they can see themselves as suffering from a mental illness. They can find some comfort in a psychiatric label, as some people do. That's absolutely fine by me. This is not about tearing diagnoses off people. But it is about giving people informed choice, and most people are not given a choice. So what I would always do is say, I wonder how you came to be given that diagnosis. Is that helpful to you, do you think, or not? Are you aware there are some criticisms of diagnosis? Are you aware that there are actually some alternatives that some people find helpful? Shall we continue to explore and discuss this a bit so you can decide what's most helpful for you? So that's an informed choice. And it's not, I think that's what we should all be doing. I don't find that a particularly difficult conversation. Many of the people I've worked with choose to still see themselves as having a mental illness of some sort at the same time as doing psychological work. Well, that's fine. That makes sense to them. I think there's a bigger question about whether we give people diagnostic labels in the first place. Now, I don't do that as a psychologist, and psychologists sometimes diagnose people in the UK, but I personally wouldn't do that. The bigger question is, how do people get hold of this idea in the first place? Why are they assigned labels which we absolutely know are not scientifically valid when we actually have alternatives? So that's my answer to that.
What are your thoughts on bringing the meetings, conversation, therapy outdoor in nature?
Well, sort of nature therapies and that kind of stuff. If that's what the questioner means. Well, fantastic. I mean, one of the things the framework is very keen to say is we don't need professional solutions for mental health problems. Well, we do sometimes, but ordinary life can be healing, nature can be healing, anything that helps you can be healing, art can be healing, music can be healing. Again, it's something that indigenous cultures know very well, and if that's helpful, well, we should all be doing more of that. I would very much support that.
Do you see any weakness with PTMF?
Weakness, goodness. Well, it's meant to be an imperfect, evolving document. It's not meant to be imperfect, but we acknowledge it's an imperfect, evolving document. Of course, it has weaknesses. So some of the criticisms we've had are, it's very hard to read. It is very hard to read, we own up to that. I think it kind of had to be, because it had to look kind of solid and evidence-based. That's why there are lots of different versions of it on the website, podcasts, interviews, and workshops and so on. It's been pointed out to us that all the main author group is white, and that's true. We had people from a number of backgrounds in the larger project group, but the actual project group itself is all white. That's probably not, well, it's not a great thing. In our subsequent work, setting up the Power Threat Meaning Framework Committee, we've tried to recruit people from a wider range of backgrounds. And we've also had feedback that we haven't sufficiently taken into account different cultural experiences, which may also be true. And one of the things I personally think we could and should have done more about is looking about experiences that people describe in religious or spiritual terms, which I think are very valid and interesting and important ways of understanding distress. We have got a pattern on the website called Spiritual Crisis, which attempts to address some of that. So there's lots to be working on, lots to developing, some holes to be filled, and the process goes on.
Will it be a version 2 or is it finished?
Will there be a version 2? The version 1 was so hellish to produce that, I mean, there was a time when we thought we'll do a second edition. I think it's much more likely we will use the website to collect different, more patterns, more examples and so on, rather than update the original, which I think would be a massive task. Although one thing I would like to do, which relates to the first questions, I think the chapter on philosophical principles, I think it's halfway there. It's not very integrated at the moment. I think that was such a big leap for us as well, digging down into the core philosophical principles underlying not just medicine, but the whole Western way of thinking, that I think we've got a way to go with that. I would like to see that particular chapter being updated at some point.
In Norway, you usually have to get a diagnosis in order to get treatment help. First, investigation. If you get a diagnosis, you get help.
Yeah.
How can it be solved?
Yes, it's not like that in the UK, fortunately, though we're moving that way. I think, we have to, the framework is both idealistic and in terms of taking it on board, we have to be pragmatic, and that's always a very difficult balance, isn't it? We might want to be here one day, but at the moment we're here. So I think the one we've said at several points in the framework, nobody should miss out on their benefits or access to service if they need a diagnosis. Of course, if someone needs a diagnosis, they should have one. And in my work as a clinician, I've often had a discussion with people about the forms they have to fill in to access certain benefits. What is different about the way I've done it, and I think this would be consistent with the framework, is to have an honest conversation about it. So there's a big difference between saying you have schizophrenia and you need lifelong support, and saying we need to put something in this box here, as we know we don't necessarily understand your problems in that way, but you do need access to this service. What would you be happy with? So it could be a negotiated compromise, if you like. And I know quite a lot of other people who play the system in that way, which I think is necessary at the moment. Maybe one day it won't be necessary. While we're on that subject, I will just mention that Chapter 8 of the main document looks at a number of areas in which diagnosis is currently necessary, including access to welfare services, including the legal system, including various other areas, including research, and suggests ways of doing it differently. So we have got a whole section on how could we access services and benefits in a way that wasn't dependent on diagnosis. So if you want to have a look at that, that might be of interest to you.
In a conversation with a client, how to create an access to a client's treat responses without being confronting, when it's a part of an identity and when a client is protecting these responses?
Well, that applies to all our work with people, I suppose. So, I mean, the framework doesn't discuss how to work at that level. As I said, you won't find anything in the framework that specifically addresses that. If I say, as a clinician and a psychologist and a therapist, I'm sure you'll all agree that you need to work with clients where they are, don't you? If something's threatening to them, then you go very carefully with it. You may need to be perhaps inviting them to step a little way ahead, but you always need to be working at people's own pace and with people's own beliefs and feelings and identities. And identity questions are particularly threatening. I think if you've constructed your identity around a certain label and it's presumably doing something for you, it's very challenging and difficult to think differently. And I think we have to go gently with people. You know, I might not agree with that, but that in a way that's not for me to decide whether or not the person holds that identity. It is for me as a professional, I think, to gently invite the person to explore that, and that exploration needs to be done, of course, with sensitivity.
Last one. Can you clarify the difference between general patterns and diagnostic criteria?
Oh God, an easy one to end with. Okay, so in the overview, we have a whole section on the characteristics of the PTMF patterns, which shows that they're very different from DSM diagnostic criteria. Lots of people struggle with the difference, and to be honest, we struggled ourselves with how to come up with a set of patterns that were fundamentally different. I think the simplest way I can explain it is that the general patterns are about narratives that are available in a particular society or culture at a particular time. So they're about how we shape our internal narratives. They are not about putting people into boxes. They are not about categories. They are not about things that have gone wrong with our body. They are about meanings. They are based on and shaped by meaning, not based on biology. And that fundamental difference leads to everything else. So you don't assign someone to a pattern, and nor does a person assign themselves to a pattern. The pattern might be a useful form of information for you to look at to think, well, that sounds a bit like me, but that might apply to several patterns. That pattern also sounds a bit like me. It's a way of introducing new ideas and new narratives to a person. It's absolutely not a way of categorizing and defining and labeling them. And it's not expert-driven. These are ideas that are available for people who may be interested, but they are optional. But if you're really interested in the patterns, as I say, I can't remember which chapter it's in, it's somewhere in the overview, there's a whole summary about the characteristics of the patterns.
Okay, Lucy, thank you very much. Skal vi gi Lucy en ordentlig applaus?
Thank you.